Okay, thanks very much, and especially thank you all to people who got me here, because it kind of was quite an epic travel management thing in the end. Anyway, but I made it, so that's great. So I'm going to talk about a global risk assessment, essentially, that was done. It's published this year, and so this is just an overview, because of course this is quite complicated. So I hope I give you enough details so you understand what we did. But I obviously not aiming to go into all the models. And also, I want to acknowledge, of course, all our co-authors. So it's a very large kind of consortium approach. And the first thing to say is, when we do all this health risk modelling, we have to know who we're doing it for. And the reason that this was done as a global modelling exercise about future impacts of climate change was that WHO had a mandate for it. In one of their Health Assembly meetings, it was clearly done that they had to do an update of the risk assessment of the global health impacts of climate change. So we had a very clear target audience. I'm just going to talk about the scenarios, because that's quite key in how you frame your assessment, of course, and it does kind of then lead to what outcomes and the results that you will get. So the framing, of course, is very important. I'll give you an overview of the results, and then I'll just talk about a couple of the models that I think aren't going to be talked about in later detail. And then I just want to introduce another thing that we did that is quite new in terms of the state of the art of the modelling, and this is the model intercomparisons. These are much more common in some of the other climate impacts areas, and certainly it's something that the climate modelers do. They compare, they put all their models together, and then they look across the range of the impacts. So it's like CMIP5 is the Climate Model Intercomparison Project, if you've heard about that. So this is global modelling. People have mentioned before that scale is very important. So some things are answered at the global scale, and your methods are different. The data that you have access to are different. So scale is so important when it comes to climate change. And of course, in terms of health priorities, we know they are hugely different. We've talked about local government, state government, national government, federal government. They all have very different health priorities. And if you're doing a health risk assessment or a health impact assessment, it's for a decision maker, and you have to be clear what questions they want you answered, basically. So there was previously for 2000, for the year 2000, WHO did do a burden of disease, it was called. This isn't a burden of disease, because we want to make very clear that it's not comprehensive. Okay, so just for people who ever have heard a quoted number of 100,000 deaths due to climate change, this WHO burden of disease assessment, that is where that is from, okay? And that was for deaths attributable in the year 2000. So that was deaths attributed for the warming that was done from the 70s up to the year 2000. So it's, in a sense, it's in the past, okay? But our work was very much focused about projecting into the future. So the results I'm going to present are not comparable at all to that result. But the outcomes that were looked at are very similar, okay? So the other thing about global modelling is particularly for the non-health sphere is that there are lots of global model projects, okay? And particularly through funding through the European Commission, the Framework 7 projects. There's been several projects where you look across a range, so you'll do food modelling, water modelling, ecosystems modelling, and perhaps health modelling. So when you're doing global modelling, which is really around sort of global impacts and basically arguments to support mitigation, it's done in a very sector-based approach. And there's always been people trying to look across sectors. So this is about interlinkages. We know that food and water interact, for example, and health interacts with a whole load of issues, heat and urbanisation, and air pollution, they're all interactive. But what we're not very good at is still modelling those interactions. So this is where we want to be, but this is not where we are at the moment. But the Quest was a UK project, Icarus is a Japanese project. People in the room probably know about a lot of these intersectoral projects that are ongoing now. And so health may well be included in some of them. And then finally, there's the model intercomparison approaches. And the only one that's been done with respect to health so far is this malaria one that I'm going to show you later. So just to put it in scenarios in context, okay, what we did was we only looked at one emission scenario, so one basically rate of climate change or emissions driving climate change, because we were mostly interested in impacts up to the mid-century. And as I'm sure you know, the effects of mitigation really don't kick in till after mid-century. So if you're ideally, you'd want to look at the benefits from going from high emissions to a low emissions and quantify that change. But we couldn't do that because we felt the underlying health assumptions wouldn't be sustainable beyond 2050. And it was on the old A1B, which is sort of a mid-high, mid-range of future climate change. We also did one population projection, which is a UN one. So that's the top left corner, the red one. So it's about 9 billion by mid-century. And, you know, we are estimating absolute burdens from climate change, and of course that is hugely dependent on the population, okay? So we stuck to a single population to just avoid confusion, because if you produced multiple estimates using different populations, then that would be driving your population burdens, basically. But what we did vary was the one on the right, which is economic growth. So the key thing about, well, what was new about this assessment is that we had underlying mortality projections, and these were produced by WHO, which I'll show in a minute. And these were produced for different assumptions of economic futures. So there was a high growth future, which you can see this is GDP per capita, which is very high. That sort of matches to an A1 scenario. Then there's a UN one, which was our kind of base case. And then we had a no economic growth scenario. So that's very pessimistic, okay, but just as a kind of a reference scenario, I guess. So what we did was we were kind of fitting in between some methods that are sort of developed within the climate impacts world, which is not health focused, and the burden of disease, if you're familiar with that, that's done through the World Health Organization and now through the International Institute of Health Metrics, which is up in Seattle. So we basically estimated for health impacts of climate change in a future world. Under that economic growth with that population, and we compared the world with climate change and the world without climate change. And the world without climate change was obviously on a baseline, the current climate, and the future climate was given to us by the climate models, right? And following sort of WHO methods, we estimated the annual burden, so the annual number of deaths. So when I show you the results, they're not cumulative, they're not the total burden, they're the annual burden. So the annual burden for 2050 and the annual burden for 2030, okay? So I think there's an issue here about what counterfactual you use. So we had a counterfactual with economic growth, with health improvement, you know, with quite a positive, healthier future world, okay? So these are the impacts of climate change under a richer, better world. And you can see on the right, so basically communicable diseases are sort of the red lines. They're also split by age. It's over time. So these are the projections of deaths by year from WHO. They also include, obviously, economic growth, but also some assumptions about smoking rates and other the major determinants. But the communicable diseases, so things like infectious disease, diarrheal disease, malaria, and malnutrition are going down as they are now, and we are expecting them to carry on to do so. And non-communicable diseases, heart disease, respiratory disease, chronic outcomes are going up, which is the blue line sort of going up, right? So deaths in children going down, death rates in children going down, death rates in adults possibly going down. It's a more complicated picture. But absolute numbers of people increasing, and absolute numbers of older people increasing, right? So to illustrate that, this is very dramatic. These are the mortality projections for diarrheal disease in children. You can see how rapid that decline is, okay? And I'm not saying this is plausible or likely, because, you know, what we have, you know, projecting future mortality is difficult, okay? And we can look at the MDGs, and we know some of the MDGs are met, but the MDG for sanitation has not been met. So this might be an overly optimistic picture for diarrheal disease. So this is the kind of overall framework. So if you look along the red, these are the outcomes that we looked at. So the other thing, of course, is that we know climate change affects a whole range of things. But when you're coming to modelling it, you have to balance confidence and quality and robustness as well. So we did have a level of robustness that we felt these models had to meet before we included them. So some models that we worked on were not included, okay? The most important one being cold. We didn't do cold-related deaths because we just didn't feel we had a robust model. But that's clearly quite an omission for that because it's also a benefit, right? So I'll say that, get that one out of the way. We also looked at occupational deaths, okay? Because remember, we only modelled, if you notice, we've kind of avoided double counting by splitting the age groups. So diarrheal deaths are in children, direct heat deaths are in over 65s, but heat in adults would have been the occupational group. But again, that model didn't quite make it to the final cut. We also modelled the impact of climate change on economic growth, and that has a relationship with mortality. So that is quite a considerable impact. That didn't make it to the final cut, but we might consider trying to publish that separately. And other models as well, like schistosomiasis and air pollution, were also discussed at some point. So we've got various levels, or the modelling streams are in various states of kind of advancement, basically. But so we've got heat, coastal flood mortality, diarrheal mortality, malaria mortality, dengue mortality, and all-cause mortality from undernutrition, okay? And as said previously by John, you know, this row here is your exposure mapping, your vulnerability mapping, which we are better at, okay? But this step, so going from mapping the malaria distributions and going from dengue distributions and mapping stunting, we have some confidence in it. But that next step, converting those into deaths, is a non-trivial step. So we had a lot of discussion about the best way to do that. And that's and that again is a novel part of this whole assessment. So we can discuss that later about how we did those steps, okay? But the requirement was to convert it into absolute deaths. And obviously we would like to convert them into DALYs as well, which would again give us a different sort of distribution of the impacts. So just to go through the results, and you may hope you can see the regions along the bottom. But basically, one of the key findings, so it's not trying to avoid focus on the absolute numbers, it's the distribution of the impact. So what's one of the advantages of doing a global assessment is that you can have a better idea of the impacts, which regions are most affected. So clearly, Sub-Saharan Africa and South Asia come out particularly at risk. So you have undernutrition and South Asia. So the blue is the 2030, and the orange is the 2050. So you've got the 2 time points there, and this is deaths by outcome. And you can see clearly that it goes down from 2030 to 2050, and that's because of the underlying mortality decline, okay? So although climate change is increasing, the crop yield changes are more dramatic, the fact that you've got less of a population at risk of malnutrition is what's driving those estimates, okay? And that's same, you see the same pattern with the diarrheal disease, but you see the reverse with the more heat-driven outcomes, where they just increase as time goes on. As climate change increases, your heat burdens are increasing, okay? And again, the regional disparity is even more dramatic for malaria. They're not all on the same scale, by the way, so it's important to notice. So it's really East Africa that is at risk of malaria increases due to climate change. And then we've got diarrheal disease and dengue. So the dengue mortality is very low, okay? It's very, very low. Dengue just doesn't kill huge amounts of people compared to these other outcomes. And then with diarrheal disease, you can see the same decline over time. Heat mortality, again, it increases, but the thing about heat-related mortality is you actually have impacts in the high-income populations. So the HIC group is Europe, North America, and Australia. That's the high-income regions all lumped together. And this is the outcome where they do show a significant burden. But otherwise, it's the low and middle-income countries that get the most affected. I know you won't be able to read this. I'm sorry about that. But people have just talked about adaptation, okay? Now, the point is we did include adaptation, and I think we did it as well as we could, because, again, we were trying to kind of work out the impacts of climate change with reasonable assumptions around adaptation and in a richer world. So this is like the high end, higher boundary of what those climate change impacts might be. And the different columns basically tell you how it depends. The adaptation is quite a difficult concept, and it can happen at different levels. So the underlying trend, that first column, is really what I was saying before about improvements in underlying health. So that's lower mortality rates from diarrhea, lower mortality rates from malnutrition, lower mortality rates from malaria. They're all built in, okay? And then you have adaptations assumptions that are explicit within each model. So the heat model clearly has an assumption about adaptation to heat. So those are included in there. And in fact, we had varying assumptions which could be tested as a sensitivity analysis. But the final estimates I showed do include adaptation, okay? But the problem is we have a lot of evidence that adaptation will occur. We don't have good evidence about what level of adaptation will occur. So that was just had to be an explicit assumption on the best evidence that we had. And the coastal flooding includes coastal defences, so that has adaptation. All the agricultural modelling have adaptations within the agricultural models, okay? And yeah, that's about it, really. And then the malaria and the dengue included socioeconomic assumptions as well. So they were modelling the benefit of climate change and development within the malaria model. So that's all kind of complicated, but the kind of take-home message is that we did include adaptation. So some results from the specific models. This is heat. And I generally don't like maps of heat, but this one's interesting because there's quite a few of these now, and they do show quite different regional vulnerabilities, really depending on your assumptions, which I think is quite interesting. But this one, this was done with the Japanese partners, this is absolute numbers as well. So remember, this is where populations are, which is why India and China are also very high for regional vulnerabilities. One thing we tried to do is model coastal flooding. Okay, this is an example of Tacloban, that huge cyclone that hit last year. And this is a horrible graph, so I'm going to try and explain it. So we have, on the right, you have the number of deaths from coastal flooding projected, okay? And then you've got time along the bottom. So the more deaths, it's redder, and as you kind of climate change or sea level rise increases, you get an increased risk. But this includes adaptation. So you have regional, these are our 21 regions. Okay, so you can see Asia, that big red bar bit, that's all Asia, because we know that coastal flood deaths are all concentrated around the Bay of Bengal, okay? These are kind of stochastic, essentially random events we're trying to model, and we can't model them very well, okay? So we would not, you've probably noticed that these deaths were not included in the previous summary results. This model does not predict deaths well. If we're modelling just the log mortality risk, it does quite well. But absolute numbers of deaths, it underestimates them because the distribution of deaths is so unequal in space and time, okay? So this is trying to just illustrate regional vulnerability. And within each region, you may not be able to see, but there are 3 bars. And the bottom bar is without climate change but without adaptation, but the top one is climate change with adaptation. So you'll see that even for East Asia, it's yellow. So the risk with adaptation, so the risk from climate change to coastal flood risk is dramatically reduced by coastal defences, as we might expect. But that assumption around coastal defences is based purely on GDP. So if the GDP, remember it's high GDP, is affordable, or you have high GDP, the assumption is you will build those coastal defences, which we know may not be actually true in the real future. Okay? So this is just some summary from the malaria models. This is the baseline data. So all these models were based on observational data. Okay, they were all they're all fitted basically with the best observational global data that was available, okay, except for the heat and the diarrheal ones, which are statistical models based from location data, so some areas. And you can see how well it does. So the red areas is when it predicts yes, so sorry. So you can read that. It doesn't do very well, okay. But I'm going to explain the relative merits of the different modelings later. And this is projections into the future. So the bottom one is with only climate change, which is what you might expect. It's this expansion at the fringes. So even with what we think is a global impact for malaria, the effects of climate change are actually very localized. So we don't have, in the way that other, the ecological models have global impacts where you can show global effects. That's not how the health system works, really. This is dengue. I can't remember saying it. This is a statistical model of dengue, and I think someone's already highlighted the weaknesses around this modelling approach as well. So there's a tension for the vector-borne disease models between the biological methods and the statistical methods as well, which we need to bear in mind. Okay, so I'll try and get through this very quickly. So this is now undernutrition, okay? So in terms of the overall impact of climate change, if you model across the outcomes, undernutrition is normally the biggest single contributing burden. And that's because the level of undernutrition within the current population is still so high. But it's a very complex chain. And this is a very complex system. And as people know, current food availability is not the best predictor of current levels of undernutrition. It's poverty, okay? So bearing all that in mind, we had to construct a special type of model. But even so, it's at this end of this very long chain. So it goes climate model, crop yield model, then it goes into a food trade model, then it's converted into national calorie availability through FAO methods. And then that outcome is what we converted into undernutrition using our health model, okay? So you can imagine the uncertainties that are propagated through that chain from model to model. I'll skip that. So, but what we have done within the undernutrition is modelled it across the three economic futures. So low economic growth, B is base case, and H is high economic growth. And that primarily drives the number of people, the number of deaths, okay? So you just get fewer deaths from malnutrition under high economic growth. But what you do get is this shift from from moderate stunting into severe stunting, which is seen more clearly here. So you've got the regions, so you've got Sub-Saharan Africa, Central, East, South, and West. So again, quite significant regional differences even within Africa. And then you see, this shows more clearly the contribution of climate change, which is the orange bits. So blue is the world, future world without climate change, and then you add in the climate change bit on the top. So you can see overall climate change is still a relatively small contribution to the overall burden of disease as well. And that was stunting, and then this other step of converting it into deaths. And for that, we used some published odds ratios from Black et al. Paper that's actually quite old now, but that was a reasonable approach. The other thing we did, which I won't go into detail, but we tried to quantify the uncertainty around them, and we were able to do this by using these PDFs. So you can see that they actually overlap quite significantly with the kind of no climate change scenario. So the uncertainty is huge. And how we communicate that uncertainty to decision makers is also very important. I think there's a lot of work to be done to communicate the uncertainties and the risks and the kind of what we know about the likelihood of really serious outcomes from climate change. just a final slide, because I know I'm running out of time, is on the malaria intercomparison models. So there are 5, there's probably another one as well, global malaria models. And you can see at the right-hand column basically tells you whether they're biological, these deterministic models, or statistical. Okay? So the LMM and Vectri were biological models. And also the Vectri one had complex models of population movement in it as well. Now this is horrible as well, but this is a kind of traditional output from the climate models about comparison. So basically where there's hatching, there's agreement across the models, okay? And we were also doing the full suite of uncertainty, so there are several climate scenarios in here. And in fact, the uncertainty between the climate scenarios is quite large, particularly around West Africa, where they don't agree on the sign for a rainfall change. So I think we do need to bear in mind that there's still a huge uncertainty, particularly for rainfall, for a lot of these projections, and that really does need to be taken into account when you're trying to do this sort of modelling effort. And then these, again, are the range, across the range from all the climate scenarios and the modelling, and you can see the range is quite large. And this is the region, so it's Central Africa, Southern Africa, East Africa, and West Africa. And basically that shows you that the only consistency is for an increase or a negative impact in Eastern Africa. For the other regions, it's either neutral or showing a benefit, but all the spreads are very large. So it's actually quite a useful exercise, because the final thing we did was showing where the main cause of that uncertainty is. And basically, so the redder it is, the bigger the source of uncertainty, and you can see it's the model. So the malaria model, which is the middle row, that's where all the uncertainty lies for those malaria projections. There's some around the modelling, and relatively little just for the emission scenario, which is the RCPs. Okay, so just to conclude, modelling global climate change impacts on human health is extremely difficult, okay? You know, we not kidding ourselves that this is an extremely complex area, and the assumptions that you include are extremely important and drive to a large extent what results you will get. And we're still only doing it for a very limited amount of outcomes, because we know that climate change will have a lot more complex effects on health and on the determinants of health particularly. But what we have shown with this assessment is that even if you assume a lot of adaptation and high economic growth, the impacts are still negative. We're not going to buy our way out of trouble. I think that's quite an important message. And it also shows, consistent with other studies, that it's quite regionally focused, the impacts as well. The uncertainties are large, and I think we need a better method of communicating and describing those uncertainties. And also they identify where the knowledge gaps are, so you can invest in future research. And we also need to understand the rate of warming is actually quite important as well. So it's this dynamic. I think this has come up before. We really need to stop these kind of static time, cross-sectional approaches, and really try and put in some dynamical systems modelling as well. Okay, finished. I'm done. Oh, time.
Blinking red light. I'd like to thank Dr. Kovats, and we have time for one question. Again, we will have a chance to go over a lot more when we do this. Again, please say your name and go from there.
Thank you. Nice presentation. Ben Beard from CDC. And my question is kind of getting into some of the underlying uncertainties and models. I guess I would ask, when you look at diarrheal diseases and undernutrition, given that those are probably multifactorial, do you feel that is a safe assumption to think that climate change is impacting each of those different diseases in the same way? Or is it possible that, whether you're talking about enteroviruses or bacteria or whatever, that they're behaving differently? And the second question related to that, in terms of imprecision in our models and the things that some of the things we need to address. I always get a little bit concerned about malaria modeling globally based on case definition. I realize that one of your slides mentioned prediction of parasitemias in children, but much of the available data sets really are just acute febrile illness and not necessarily malaria. In some studies, as little as 50% of these AFI cases are actually malaria, even though that's what we assume they are. And so I would ask you if you have thoughts about that and how we deal with those uncertainties in models.
Well, on the malaria thing, that malaria model was based on the Malaria Atlas project. So I've taken that as the state of the art. So you'd have to take it up with them, I suppose. And your point on the diarrheal disease, I didn't mention it, but it was a very simple model and based, very similar to the heat modelling, based on what, local studies about the effects of temperature on diarrheal diseases. And I would love to do it by different pathogens as well. So if someone wanted to give me a large research grant, I would very happily do that.
Thank you, Dr. Kovats. Again, we will have a session with a panel, and you can address more questions. I would next like to introduce Dr. Michelle Bell, excuse me, from Yale University.